Good evening again, and we're going to continue talking about renal disease. And we're going to start out tonight with renal vascular disease. Renal vascular disease are various processes that affect the renal arteries that may severely narrow the lumen and greatly reduce the blood flow to the kidneys. These are things like atherosclerosis or renal vein thrombosis. These usually occur with the sudden onset of hypertension. So when we're doing an assessment, there is a chart on, sorry, don't know the page, but chart 67.6 tells the key features that you need to be looking at. So some of the things that we look at are significant and difficult to control high blood pressure. And this high blood pressure, this hypertension, occurs around the age of 40 to 50 without there being any family history of hypertension. We may see poorly controlled diabetes or sustained hyperglycemia in these patients. They may have elevated serum creatinine levels and decreased glomerular filtration rates, or GFRs. The diagnosis is made by magnetic resonance angiography. So in this case, it's similar to an MRI, but they're looking specifically at the arteries. They may do radionucleotide imaging, and with that, they may use an ACE inhibitor because that improves the accuracy of the test. So if you were to take care of a patient that had this as a potential diagnosis, you would expect that in their MAR, they would have a one-time dose for an ACE inhibitor. As far as interventions go, the treatment is based on the type of defect that's causing the narrowing, how bad the narrowing is, and the condition of the surrounding blood vessels. Some of the drugs that they may use include drugs for high blood pressure like ACE inhibitors and ARBs. They may do endovascular techniques, things like stents or balloon angioplasty of the renal vessels. So if you look at the picture that is on the left as you're looking at this screen, you'll see that they are doing a catheter and balloon angioplasty on this particular renal vein. And in the lower picture there, they've put in a stent to hold that vessel open so that that narrowing no longer exists. Renal bypass is what we're seeing on the second picture, where they don't use the same insertion area. Usually the narrowing tends to happen at that junction between the renal artery and the kidney. And so usually what they'll do is put the bypass graft a little lower than the original vessel. And you can see that in this picture. Renal bypass surgery usually requires 2 months for recovery. Diabetic nephropathy, and you should be somewhat familiar with this, having had your diabetic lecture just not that long ago. It is a vascular complication of type 1 or type 2 diabetes. It's the leading cause of end-stage kidney disease, or ESKD. And what happens is we have a patient that had poor control of their hyperglycemia. And the complicating problems that come with hyperglycemia of atherosclerosis, hypertension, and neuropathy, which promotes loss of bladder tone, urinary stasis, and urinary tract infections. And they're more severe and more likely to cause kidney damage. The severity is related to the degree of hyperglycemia that the patient generally is experiencing. So this doesn't necessarily happen to people who have an occasional high level of glucose. It's more likely to happen with patients that consistently run high blood glucose levels. Management is the same as for chronic kidney disease, and we're going to be talking about that later in this lecture. Renal cell carcinoma is usually an adenocarcinoma in the kidney. It's the most common type of kidney cancer, and it usually metastasizes to the adrenal gland, the liver, the long bones, or the other kidney. So often what you have to think about with metastasis with cancer is it tends to first go to whatever organ is closest to it. So when you think about it, remember when we were doing the endocrine lectures, that adrenal gland sits right on top of the kidney. So if you have a cancer in the kidney, it's more likely to go into that adrenal gland because it's just right there. It causes non-hereditary renal cell carcinomas. They're unknown, but the risk is slightly higher for adults who use tobacco or exposed to cadmium or other heavy metals. Also things like asbestos, benzene, and trichloroethylene. Men are slightly more likely to acquire renal cell carcinoma. Also, people that are obese, African American, or people who are hypertensive. So when we're looking at assessment or the noticing phase, we're going to want to ask about age, known factors, weight loss, urinary changes, pain, and fever. These systemic effects occur with this type of cancer are called paraneoplastic syndromes. They include things like anemia, erythrocytosis. Erythrocytosis is a condition in which your body makes too many red blood cells. Also with hypercalcemia, liver dysfunction, with elevated liver enzymes, hormonal effects. Remember, your adrenal glands function off of hormones, so we'll see changes in those hormone levels. And increased sedimentation rates and hypertension. So what we know is that as far as the erythrocytosis is concerned, is that some of these cancer cells will overstimulate and make more erythropoietin than what the person needs. Erythropoietin is the hormone that causes the bones to produce more red blood cells. And that's how this person ends up with a high hematocrit and will also have signs of erythrocytosis. Also, they may have flank pain. They may have obvious blood in their urine. That's usually a late sign of this cancer, and you may be able to feel a kidney mass. The urinalysis, hematologic studies, BUN, creatinine, CT, MRI, ultrasound, and kidney biopsies are other ways that we diagnose for this. Remember too that the parathyroid hormones produced by the parathyroid hormone that's produced by tumor cells can cause hypercalcemia if this has metastasized to that area. And other hormone changes can include increased renin levels, and renin controls your blood pressure, so if you have increased levels, then you're going to have hypertension. Increased human chorionic gonadotropin, or HCG levels, may cause a decrease in libido and changes in secondary sex features. We want to make sure that we inspect the skin for pallor, darkening of the nipples, And in men, we may see breast enlargement, and we call that gynecomastia. It's caused by the changing hormone levels. So if they aren't producing enough testosterone, they have the tendency to develop breast tissue. Other findings can include muscle wasting and weakness and weight loss, and they all tend to occur late in the disease process. On urinalysis, we may see red blood cells. Hematologic studies may show decreased hemoglobin and hematocrit values, hypercalcemia, increased erythrocyte sedimentation rates, and increased levels of adrenocorticotropic hormone. Also, we may see increased levels of human chorionic gonadotropin, or HCG, cortisol, renin, and parathyroid hormone. We may also see elevated serum creatinine and blood urea nitrogen levels, which would tell us that there's impaired kidney function. The kidney masses are more likely to be detected by a CT scan or an MRI. And ultrasound is also used to detect masses or for the initial screening. The kidney biopsy may be considered to help target therapy. So when we look at interventions, the first thing that we look at are things that are going to help us to control the cancer. And these include things like non-surgical management, like microwave ablation or cryoablations. Cryoablations are freezing of the tumor, which will slow down the tumor growth. Microwave ablation is used most commonly for patients who only have one kidney or who are very poor surgical candidates. Traditional chemotherapy doesn't tend to work with this type of cancer, although they are using some biologic response modifiers like interleukin-2, interferon, and tumor necrosis factor. And that's increased survival time for many of these patients. But that's why we would do a biopsy, because then we would find out which one of these biologic response modifiers would work the best for that patient. As far as surgical management to control the cancer, the most common treatment for renal cell carcinoma is a nephrectomy, which means we're going to take out the whole kidney. When the cancer is local or only in the kidney, it can provide a cure. So in other words, if it hasn't spread to other organs, this will take care of it. It removes the cancer out of the body. For patients that have metastasis, they may do a nephrectomy and then follow it with chemotherapy. Patients that have renal cell carcinoma are at risk for chronic kidney disease and cardiovascular complications. They need ongoing interprofessional care and when they have that care, they have better outcomes. Follow-up therapy is managed on an outpatient basis. One of the things that you need to know as far as surgery is concerned is that these renal cell tumors tend to be very vascular. So that means that when they start doing surgery, there's a lot of bleeding. And that's always a major concern. So before surgery, often what they'll do is occlude the arteries for the kidney by embolization. And usually an interventional radiologist does that procedure, and that will reduce this amount of bleeding during the surgery. Post-op care, we want to monitor for hemorrhage and adrenal insufficiency. We're going to inspect the patient's abdomen for distension from bleeding. And in addition, You don't want to just look at their abdomen because sometimes they sort of ooze around their incision, and they can actually end up laying in a pool of blood. And so you want to make sure that you are turning the patient and really looking under them to make sure that there isn't bleeding that you're missing. Um, Hemorrhage and adrenal insufficiency both can cause hypotension and decreased urine output and an altered level of consciousness. So you can't assume that it's one or the other because it could, if you discover that they've been bleeding, then yes, it's the bleeding. They need more volume, and they'll probably get blood transfusions to replace that blood volume. But they could have adrenal insufficiency. And so with that, uh, then we need to give them steroids because we're replacing what the adrenal glands are not putting out, and that can cause them to have raise their blood pressure back up to normal levels. On the other hand, we may have a combination of both. Because if you remember, with acute adrenal insufficiency, surgeries can be the cause of that happening. Also, a decrease in blood pressure is an early sign of both. With hypotension, the urine output tends to decrease immediately. So what we'll see, even before we see the numbers change with the blood pressure, we'll see that they aren't voiding. And so that's definitely one of those emergent things that we want to report. They may have large water and sodium losses in the urine if they have adrenal insufficiency, and that can lead to an impaired fluid and electrolyte balance. So they would be hyponatremic because of the loss of their sodium. When you have large amounts of urine output, you also are losing fluids, and so this is often followed by hypotension and oliguria. Oliguria is considered to be less than 400 milliliters in 24 hours or less than 25 milliliters in an hour. And so often we will do IV replacement of fluids and packed red blood cells for the bleeding and the increased loss of fluids. The second kidney is expected that it's going to provide adequate function and take over for the one that's lost. But it can take days or even weeks for that to happen. So we want to assess the urine output hourly for the first 24 hours after surgery. And so we often look to make sure that they have a urine output of more than a half a milliliter per kilo per hour, or about 30 to 50 milliliters per hour. We tend to use the milliliters per kilo per hour more for children, and the volume, the 30 to 50 milliliters, for adults. So we don't really want it to be less than that amount. We consider in the immediate post-operative phase that this is adequate urine output. A low urine output of less than 25 to 35 milliliters per hour suggests decreased blood flow to the remaining kidney and potential for acute kidney injury. And we talked before about AKI. The hemoglobin level and hematocrit values and white blood cell count will probably be measured about every 6 to 12 hours for the first day or two after surgery, because we're monitoring for bleeding. We're going to make sure that we weigh the patient daily, and not only that we're weighing them daily, but we're weighing them on the same scale every day, because every scale has its own normal. A 0 on this scale and a 0 on this other scale are not always equal. And I think that The girls in this class would probably tell you that they either love or hate their doctor's scales compared to their home scales, because either the doctor's scales weigh them more than what their scale at home weighs them, or it weighs them less and then they love it. So that's an example of how different scales can be. They can be 2 or 3 pounds different. And so that's why we want to make sure that we're weighing them on the same scale. Having kidney surgery at any time is a very painful procedure. And because of its closeness to the diaphragm, it can make deep breathing really uncomfortable. And that means that this patient is also at risk for atelectasis, or collapse of the lung. The symptoms of atelectasis are fever, chills, thick sputum, and decreased breath sounds. Can either be reflective of the atelectasis, or it can be reflective of development of pneumonia. So when we want to make sure that these patients are not in pain, so usually they require an opioid analgesic like hydromorphone, which is also known as Dilaudid, or morphine, and it's given IV. It's not given IM. It's given IV so that they get a quick response to it. Like I said, the incision is made through major muscle groups, and it's also near the diaphragm. And so it definitely, if they're in pain, they're not going to breathe as deeply, and that puts them at higher risk of developing pneumonia. Normally, we're very liberal in the use of opioids in the first 3 to 5 days after surgery because the pain is so severe. We can try to give them oral pain medications once the patient is able to eat and drink. We want to prevent complications. So often antibiotics are prescribed during and after surgery to prevent infection. And they may need additional antibiotics if there's any evidence of infection after the surgery. We want to make sure that we assess the patient at least every 8 hours for any indication of systemic infection or a local wound infection. Adrenal insufficiency is possible as a complication of kidney and adrenal gland removal. It's not unusual when they're doing a nephrectomy to actually take the adrenal gland as well. And so although you only need one adrenal gland, that remaining gland may not be able to secrete enough glucocorticoids immediately after surgery. It may need a little bit of time to catch up to the demand. And so we need to make sure that steroid replacement is available for those patients that are showing symptoms of adrenal insufficiency. If we aren't careful with these patients, they can actually develop chronic adrenal insufficiency, like we talked about when we were talking about acute adrenal insufficiency and chronic adrenal insufficiency. As far as kidney trauma is concerned, so we're shifting gears here. It can be caused by a number of things. It can be caused by a penetrating wound. It can be caused by blunt injuries or urologic procedures. It's classified into 5 grades depending on the severity. Grade 1 consists of a low-grade injury in the form of kidney bruising. When the kidney is bruised, it doesn't tend to function quite as well. Like anything, you get bruised and it hurts and it doesn't function as well. Grade 5 represents the most severe variety of kidney trauma, and it's often associated with shattering of the kidney and tearing of the blood supply to the kidney. Obviously, adults of any age can suffer kidney trauma as well as children. So when we're looking at somebody who potentially may have a kidney trauma, we want to obtain the health history and information about the trauma. Specifically, we want to know the mechanism of the injury to help determine what the potential for the severity of the injury is. We want to assess pain. We want to assess the urine, and we want to assess circulation. Ureteral and renal pelvic injury often causes diffuse abdominal pain. And the urine outside of the urinary tract may actually be visible. We want to ask the patient about pain in the flank or the abdomen. And if the pain is dull, if it's sharp, if it's constant, if it's intermittent, is it made worse by coughing? So we really want to do a thorough pain assessment. We also want to assess patients with kidney injuries carefully and thoroughly. We want to take the patient's blood pressure, do an apical and peripheral pulses on them. We want to look at the respiratory rate and their temperature. When we're inspecting their flanks, we want to look for bruising, asymmetry, or the actual injury. So if there's a penetrating injury, we are going to want to assess that and make note of it. We also want to inspect the abdomen, the chest, and the lower back for bruising and wounds, because the bleeding can travel to those areas and actually cause bruising in those areas. We want to percuss the abdomen for distension and inspect the urethra for blood. So you actually want to get and look at the urethra to see whether there's bleeding coming from the urethra, which would tell us that there's bleeding farther up the urinary tract. Some of the diagnostic procedures include an ultrasound and a CT. The CT scan shows greater detail about the blood vessels and the tissue integrity. It can also show hematomas within or through the kidney capsule and the integrity and the patency of the urinary tract. If the patient is being taken to the operating room emergently, they may give a high dose of ionic or non-ionic IV contrast material given so that they can follow up with an abdominal x-ray, and that will help them to visualize the traumatic injury and any organ damage. So when we look at the interventions, as far as non-surgical management is, drug therapy that's given are things like for bleeding prevention or control of bleeding. They may need clotting factors like vitamin K. They may need platelets, and those are given as needed. Fluid therapy restores the circulating blood volume and ensures adequate kidney blood flow. So remember that when you're bleeding into a large space, like the abdomen, certain areas around the brain are also large areas where there can be a large amount of blood in the area. It can affect the blood pressure and the blood volume. And so they may need fluid replacement, and that may be given with crystalloid solutions. Normally, we don't look at giving plasma initially, but if the bleeding is extensive, there's they may give packed red blood cells to restore hemoglobin and promote oxygenation. They may give fresh frozen plasma or coagulation factors to help with any uncontrolled bleeding. They may give plasma volume expanders like dextran or albumin, and that helps to restore the plasma oncotic pressure, and it reduces the onset or severity of shock or fluid displacement to the interstitial tissues. So remember that the body tends to pull fluids where there's the highest concentration of electrolytes. So if there's been a lot of bleeding, the highest level of electrolytes and the highest level of fluids are out in the interstitial area, and so that's going to pull fluids that direction, and it's actually going to make edema more, they're going to become very edematous. Also, one of the reasons that they tend to give crystalloid solutions rather than giving albumin, except for severe bleeding, is that the albumin will tend to be absorbed into the interstitial space, and it will ultimately make the edema worse over time. And that's why they give the crystalloid solutions. During fluid restorations, we give fluids at the prescribed rate, and we monitor the patient for signs of shock. We want to take vital signs as often as every 5 to 15 minutes. Usually these patients are on monitors, and so we're going to be actually writing down their vital signs that often. We want to measure and record their urine output every hour. In some cases, I've seen them do it every half hour because of the concern about acute kidney trauma. And the output should be greater than a half a milliliter per kilo per hour in that case. The interventional radiologist may use percutaneous or other instrumentation to drain collections of fluid or to embolize the clot, or to embolize, which means to clot the artery or the artery segment, or to place a stent to repair the urethra or the ureters. When we look at surgical management, and I have to say, sometimes when we talk about interventional treatments, it's very close to surgical treatments, but not quite as intense. With the surgical management, most kidney injuries are managed without any surgery. However, they may do an exploratory abdominal surgery to look at the injured kidney, especially if the patient is in shock and if they're losing a lot of blood from the kidney. They may also do it to look for other abdominal injuries, like injuries to the bowel, the spleen, the liver, and so they may take that time to inspect all of the organs while they're in there and take care of the injured kidney at the same time. So the aim of the surgical management is to repair the injured kidney and restore its elimination function. If this kidney is severely injured, they may do a nephrectomy. So when we start looking at transitioning from the hospital to home, or even looking at coordination of care, the most common complications of kidney injury is urine leakage and delayed bleeding. So we want to make sure that the patient is checking the pattern and frequency of their urination and noting whether the color, the clarity, or the amount of urine appears normal. Also, they may they're at risk for developing an abscess surrounding the kidney. And so we want to instruct the patient to seek medical attention for worsening hematuria or any worrisome change like pain with voiding, chills, fever, lethargy, and cloudy, foul-smelling urine, because that can indicate a urinary tract infection or an abscess formation. The traumatic kidney injury can also cause hypertension from changes in the perfusion. And with that change in perfusion, it may activate the renin-angiotensin-aldosterone system, or the RAS system. And with that, we want to advise the patient to seek medical care promptly for all new and concerning signs or symptoms. This is definitely, we're going to emphasize to them that this is definitely not one of those things to wait and see how things turn out, that when they first notice these changes, they need to notify their physician or provider. So let's look over a case study. We have a 35-year-old patient who's admitted to the emergency department with fever, chills, and severe right flank pain. His heart rate is 112 per minute, and his respiratory rate is 32 per minute. He was recently treated for a urinary tract infection. Assessment reveals tenderness of the right costovertebral angle, or CVA. So what diagnosis does this nurse expect? And what laboratory tests does the nurse anticipate? So knowing that this person had a urinary tract infection, remember urinary tract infections can be all the way from a bladder infection all the way up to kidney infection. So we're not really talking about what degree of urinary tract infection we have here. So we would expect that, considering all of his symptoms, that he probably has acute pyelonephritis, that the infection has moved up into his kidney. We would expect, labs that we would expect would be a urinalysis, and we would most likely see positive leukocytes. We may do a nitrite dipstick test. We may see the presence of white blood cells and bacteria in the urine. We would expect that they would do a urine culture and sensitivity. We would also do blood cultures because this person has had this for a while. So we want to make sure that the bacteria has not crossed over into the bloodstream. We would do C-reactive protein. C-reactive protein checks for inflammation. That's all it does. It doesn't tell us, yes, this person has an infection, or no, they don't have an infection. All it tells us is that whether or not this person has inflammation. So the C-reactive protein in somebody who has pyelonephritis would be elevated. Anything less than a level of 1 is considered to be normal for a C-reactive protein. Anything above that is considered to be abnormal and reflective of some type of inflammatory process. But just remember, he may have arthritis or something else that would cause an inflammatory reaction. And so an elevated C-reactive protein may not be reflecting his kidney infection, but reflecting something else. Also, an erythrocyte sedimentation rate, or an ESR is another way that we phrase those. And those are the labs that we would be looking at. So, which imaging test does the nurse expect to be ordered for this patient? An abdominal CT, a thoracic MRI, an abdominal X-ray, or an IV urography? So if we think about it, the abdominal CT scan may show us something, it might not show us anything. The thoracic MRI is totally inappropriate because our kidneys are not in the thoracic area, and so that would be totally inappropriate. An abdominal x-ray isn't going to show a soft tissue, so that's another thing that wouldn't be very helpful. But the IV urography or x-ray of the kidneys, ureters, and bladder uh, is performed to diagnose stones, obstructions, uh, and so that actually would help us. 2 days later, during morning assessment, the patient expresses embarrassment about his illness. He says that he did not take all of the antibiotic prescribed to treat his UTI 2 weeks ago. What is the nurse's best response? You should always take antibiotics as prescribed. Why didn't you take all of your medication? C, do you realize that when you don't take your antibiotics, superbugs can develop? Or D, can you tell me more about why you didn't take all your antibiotics? So you all are taking psych. You all are learning about therapeutic communication. So when we look at these questions, the first one doesn't really give us any information at all. It really is just the nurse making a comment. So it certainly doesn't encourage us to find out what was going on with this patient and why he didn't take his antibiotics. Saying, why didn't you take all your medication, is really one of those types of communication that's going to close somebody down, and they may or may not answer the question truthfully. And telling them about superbugs, yeah, that doesn't really encourage communication as well. But when we ask them if they can tell us more about why they didn't do it, that's an open-ended question that's going to allow them to express what they were thinking when they stopped taking the antibiotics. It's non-judgmental, and it gives us an opportunity for patient teaching because then we find out what's going on. So moving on to chapter 67. Questions. Sorry, we were in 67. We're talking about questions now. So a nurse is caring for 4 patients. Which patient does the nurse identify as at highest risk for acute pyelonephritis? A 19-year-old male with spinal cord injury, a 27-year-old female with urinary reflux, a 37-year-old male with HIV infection, or a 44-year-old female with urinary tract stones. So if we look at these patients, let's start weeding them out. The 19-year-old male with a spinal cord injury in and of itself doesn't put him at higher risk than anybody else because he did have a normal urinary tract prior to his injury, or at least we can make that assumption. The 27-year-old female with urinary reflux, that's one that I definitely want to kind of put off to the side and say, yeah, I'm thinking that might do it because with the reflux, it could actually encourage bacterial growth. The 37-year-old male with an HIV infection in and of itself does not make him at any higher risk of a urinary tract infection than anybody else. The 44-year-old female with a urinary tract stone may have hydronephrosis, which increases their risk, but it doesn't increase their risk as much as that 27-year-old female with urinary reflux. Question 2. The nurse is caring for a patient with polycystic kidney disease. Which assessment finding requires immediate nursing intervention? A temperature of 99, blood pressure of 170 over 90, heart rate of 100 beats per minute, or urine output less than 30 cc's per hour. By the way, I didn't write these questions, but cc's is not the proper way to discuss volume and liquid volume. It should be milliliters per hour. So when we look at this, 99 is not an outrageous temperature. It depends on what time of day and things like that with it. Blood pressure of 170 over 90. So think about it, is this a normal blood pressure? Obviously it's not. This patient is hypertensive. So patients with polycystic kidney disease often have high blood pressure. And the cause of their hypertension is related to the kidney ischemia from the enlarging cysts. Remember the picture of all the big, almost blistered looking like things on the kidney. And as the vessels are compressed and the blood flow to the kidney decreases, the renin-angiotensin system, or the RAS system, is activated and it raises blood pressure. Control of hypertension is a top priority because proper treatment can disrupt the process that leads to further kidney damage. And finally, number 3, which assessment finding does the nurse anticipate for a patient with chronic glomerulonephritis? You're going to select all that apply. So the first one is increased urinary output. So do they have increased urinary output? One way of looking at the select all that apply questions is to look at each answer as a potential true or false question. So do patients with chronic glomerulonephritis have increased urinary output? True or false? No, they have decreased urinary output. So that's definitely a wrong answer. Specific gravity of 1.010. So do they have low specific gravity? And yes, they do. So that would be one of your select all that apply. C, red blood cells in the urine. So do we expect to see red blood cells in the urine of somebody who has chronic glomerulonephritis? So we have inflammation of the glomeruli. And yes, that can result in red blood cells being in the urine. So that would be another correct answer. Serum creatinine of less than 6. Normally with glomerulonephritis, they would also have decreased serum creatinine. And so that would also be because they would have a decreased serum creatinine of less than 6 milligrams per deciliter. And a sodium level of less than 135. We would actually expect for them to have a sodium level of more than 135. So that would not be correct. So B, C, and D would be the correct answers on this one. Moving on to chapter 68. In this chapter, we're going to talk about patients with acute kidney injury and chronic kidney disease. We'll also be talking about patients receiving hemodialysis. Acute kidney injury. In this case, we're not talking so much about trauma like we were in chapter 67, but injury that is reflected in the function of the kidney. And so with other diseases of the urinary tract, we've sort of talked about potentially that it may cause acute kidney injury. And there's a table at the beginning of this chapter that compares acute kidney injury to chronic kidney injury. And that would be a really good resource for you as you're looking at the differences as far as how they present and how we treat them. So with acute kidney injury, or AKI, it used to be called acute kidney failure, and you'll find in this um, PowerPoint that I actually kind of go back and forth between those two uh, names because we still have people calling it acute kidney failure. And in most cases, it's a temporary condition where the kidney is not functioning, or at least it's not functioning adequately for what the body needs to dispose of those waste products. Um, the most current definition of AKI is an increase in serum creatinine by 0.3 milligrams per deciliters, or more than 48 or more within 48 hours, or an increase in the serum creatinine to 1.5 times or more from baseline, which is known or presumed to have occurred in the previous 7 days, or a urine volume that's less than 0.5 milliliters per kilo per hour for 6 hours or more. Kidney injury also causes systemic effects and complications. You can find those in Table 68.3. Please be sure to be familiar with these effects and the signs and symptoms. These complications increase discomfort, and they also increase the risk for death from the kidney injury. We also know that the duration of oliguria or anuria, oliguria is low urine output, anuria is no urine output, closely correlates with lack of recovery of the kidney function. The longer that happens, the less likely that the patient will return to full or baseline kidney function. So what we see with it is a rapid reduction in the kidney function, and it results in failure to maintain fluid and electrolyte balance and acid-base balance. It occurs over a few hours or a few days, and it causes systemic effects and complications, and it can result in death. The etiology is that you actually, on Table 68.4, lists a whole bunch of different conditions that can result in AKI, but ultimately the causes are reduced perfusion to the kidneys, damage to the kidney tissue, and obstruction of the urine outflow. Those basically summarize what's happening with it. Diseases and conditions that are associated with reduced kidney perfusion, kidney damage, and urinary obstruction are the ones that are listed there on 68 in that table. And the diseases in Table 68.3 are described in other places in the textbook as far as how the damage to the kidney takes place. Pre-existing reduced GFR or elevated albumin-creatinine ratio. Anyone who has that prior to hospitalization is at increased risk for developing acute kidney injury. And it's more likely to occur in hospital adults with advanced age, or who have pre-existing conditions like hypertension, diabetes, peripheral vascular disease, liver disease, or chronic kidney disease. So you can actually have chronic kidney disease, and it will, and then have something happen, and acute kidney disease will happen as well. So you can have a combination of both of them. We often divide this as being pre-renal. Pre-renal is usually caused by reduced perfusion with a sustained mean arterial blood pressure of less than 65, and it's classified as pre-renal failure. It's the most common cause of AKI in acute care, especially in ICUs. Intrinsic is when there is damage to the kidney tissue um, by either an intrarenal or an intrinsic renal failure. And it reflects an injury to the glomeruli, the nephrons, or the tubules. Postrenal is when there's obstruction of the urine flow. It's also called postrenal failure. And with prerenal or postrenal pathology, the kidney normally compensates by one of three responses of constricting the kidney blood vessels, activating the renal and angiotensin aldosterone pathway, or the RAS, and releasing antidiuretic hormone. And with those responses, what we get is increased blood volume and improved kidney perfusion. But these same responses reduce the urine elimination, and that results in oliguria, or output of less than 400 milliliters per day. It can also result in azotemia, which is the retention and buildup of nitrogenous wastes in the blood. Remember that nitrogenous wastes are caused by breakdowns of protein. And those toxins can cause blood vessel constriction in the kidney, and that leads to reduced kidney blood flow and back to the oliguria and the azotemia. Activated immunity and damage from the kidney toxins, we call them nephrotoxins, cause intracellular changes in the tubular system in the kidney tissue. So those are our intrarenal or intrinsic renal failure. And inflammatory proteins and immune-mediated complexes can damage the cells and also the tissues of the kidney. When we have extensive damage, these cells will actually slough, and the nephrons lose their ability to repair themselves. And the presence of that debris, that sloughed off cells and the sediment ends up in the urine. And that is one of the things that helps us to determine that there's intrarenal failure or acute tubular necrosis. And it's related to the systemic ischemia, reduced kidney perfusion, and nephrotoxin exposure. So some of the things we want to do is to prevent this from happening in the first place. And so the first thing we want to do is to avoid dehydration. Sorry for missing that N that should be up there with hydration, by drinking 2 to 3 liters of water a day. And I know most people kind of look at it and go, there is no way that I can drink that much in one day. But that is really the best way to avoid dehydration and damage to our kidneys. You need to keep in mind that dehydration reduces perfusion, and that can lead to AKI even in adults who have no known kidney problems. So we need to make sure in our teaching that we advise adults to avoid dehydration by drinking the 2 to 3 liters of water per day. And it's especially important for athletes or anyone who performs strenuous exercise or work and sweats heavily, like during the summertime when people are out working on construction or in the fields. We want to, as far as physical assessments, we want to be aware of urine characteristic changes. If a patient has a urinary catheter, we want to assess the urine output every hour after surgery until stable. During fluid resuscitation for shock or hypotension, and when the patient has a high risk for AKI following a hospital admission. Even a brief period of oliguria can signal AKA and get AKI started. Other symptoms are related to the buildup of nitrogenous wastes, so we want to avoid those nephrotoxic substances, and increased urine or decreased urine output. And as the AKI progresses, the patient may have symptoms of fluid overload because the fluid is not being eliminated. And so you want to remember that signs of fluid overload include listening to their lungs and hearing crackles. We may see dependent or generalized edema. And when we're talking about generalized edema, we call that anasarca. And we may see decreased oxygenation, and that is related to low peripheral oxygenation or saturated oxygen. With that, we may see confusion, increased respiratory rate, and dyspnea. And we're not going to talk too much about that because we talk more about these kinds of issues next year in respiratory and cardiac. We also want to evaluate vital signs to recognize early hypoperfusion and hypoxemia. We want to look for symptoms of reduced blood volume, like the mean arterial blood pressure that's less than 65. If there's tachycardia, when we're feeling pulses, are the pulses thready or decreasing cognition, may indicate a risk for AKI due to the poor perfusion. And it may indicate potential hypoxemic or ischemic changes in the kidney tissue. So with renal failure, it's a condition in which the kidneys cannot concentrate urine, conserve electrolytes, or excrete waste products. It can be acute, we call it ARF or AKI, or chronic, so CRF or CKI. When acute renal failure continues to progress, it becomes chronic, and it also is known as end-stage renal disease, or ESRD. At that point, dialysis and kidney transplantation are the treatment modalities that are used when patients go into end-stage renal disease. When we're assessing, we want to assess for urine characteristic changes or obstruction problems, recent surgery or trauma, drug history, because we know that there's certain drugs. So remember those drugs that can cause kidney or are toxic to the kidney, like gentamicin and vancomycin. We say that they're nephrotoxic, which would mean that they would be an intrinsic kidney failure because it would cause damage to the kidney itself. We would want to look at coexisting conditions like diabetes and glomerulonephritis. We want to look at acute illnesses, especially if we believe that it's an immunity-mediated AKI, and anticipate AKI after any time where somebody may have had hypotension or shock. So if we've had to code a patient and it's taken us a bit to get them back, we would expect that they're going to have AKI. Some of the other things that we're going to look at as far as the physical assessment, watching the hourly urine output, assessing for fluid overload, evaluating vital signs for hypoperfusion and hypoxemia. We're going to be monitoring the lab assessments, especially creatinine, BUN, electrolyte values, and urine tests. If the kidneys aren't working properly, they're not going to reabsorb the electrolytes and they're not going to expel excessive amounts of electrolytes. So we'll see changes in those electrolyte values and also any urine tests that they do. When we look at imaging assessments, we may look at an ultrasound of the kidneys, a CT, x-rays that look specifically at the pelvis, the kidneys, and with that, that would be a KUB, and the MAG3s. Other diagnostic assessments might be a kidney biopsy to look at damage of the kidney. Some of the complications from acute renal failure, or AKI, is hyperkalemia. And this tends to be the most immediate threat. As we know, hyperkalemia can cause changes in the way the heart beats, and so we may see dysrhythmias. Hypertension, because again, that RAS system, the RAS system has been activated and caused the hypertension. We may see anemia. If this has been something that has gone on for a few days, when the kidney isn't functioning, it's not producing that erythropoietin, and so it's not stimulating the body to produce more red blood cells. And over time, those blood cells that were perfectly okay are now dying, and so we may see the development of anemia. We may see seizures from the end products not being released into the urine, and we could have cardiac failure with pulmonary edema. They also have a tendency to develop water intoxication because they have oliguria, so they have too much fluid on board, and hyponatremia. So we have hyperkalemia and hyponatremia. And the hyponatremia that we have is a dilutional hyponatremia because of too much fluid circulating. Some of the other things we want to do in responding with interventions is to avoid hypotension and maintain fluid balance. So when we start to see that mean arterial pressure dropping, we're going to let the doctors know about it right away so that they can respond appropriately with support with dopamine or dobutamine to protect the kidney. Also, we're going to want to reduce exposure to nephrotoxic agents. So these are going to be substances that can't be avoided. So we want to monitor drug levels, communicate with the pharmacist so that they can adjust the doses to minimize any harm to the kidney. And we also have to be careful when we use contrast mediums because they can have serious toxic effects on the tubular cells. So you want to think about the two drugs that are known to be nephrotoxic, which would be gentamicin, vancomycin, but even Lasix can be nephrotoxic. We want to frequently monitor lab values. We want to closely watch I&O. We want to observe about new onset or increased peripheral edema, increased daily weights, reduced urine output, because these may be showing that the kidneys are not functioning well, and they may require treatment with fluid restrictions or diuretic therapy. We could also see impairment of acid-base balance and electrolyte imbalance that may require treatment, especially in older adults. We want to look at drug therapy. And we've talked a little bit about some of the drug therapy that we may see. The interprofessional team, the inpatient pharmacist is often the person that we do consults with for drug adjustments based on the kidney function. And as it changes, the drug dosages are changed. And it's important to be knowledgeable about the site of drug metabolism, especially when giving these medications that are ultimately excreted through the kidneys. We want to continuously monitor the patient for AKI for adverse drug events and interactions of the drugs that they may be receiving. Diuretics may be used to increase the urine output in AKI. However, the diuretic-induced urine output does not preserve the kidney function, and it does not stop AKI either. But they do rid the body of the retained fluids and electrolytes in patients that have AKI, provided it hasn't progressed to end-stage kidney disease. We want to look at nutritional therapy. Patients who have AKI often have a high rate of catabolism, which means that they have an increased level of protein breakdown. And they also have increases in metabolism that can be related to the stress of their illnesses. And that will increase the blood levels of catecholamines, cortisol, and glucagon. And the rate of protein breakdown often correlates with the severity of the uremia and the azotemia. And remember that the catabolism is breaking down the protein is what's causing the azotemia to start out with. So we often have a dietitian that is checking in on these patients and making consults and giving advice on how to better meet the needs of these patients. If high potassium levels are present, then they're going to have their potassium restricted. They're going to be looking at their daily fluid, which is going to be usually the amount that they've voided plus about 500 milliliters for what we call insensible water losses, the water that we lose through our respirations and our sweat. And we're going to assess food intake every shift to make sure that the caloric intake is adequate. These patients may need to have oral supplements. They may require enteral nutrition, which would mean NG feedings. They may need parenteral nutrition, meaning IV nutrition or hyperalimentation. And they may need specialty formulas for people that have kidney problems. And those formulas are lower in sodium, potassium, and phosphorus, and they're higher in calories than standard feedings. Usually that enteral nutrition is either given by an NG tube or an NJ tube, and they are used for that nutritional support. We also need to look at potential kidney replacement therapy, which could be intermittent versus continuous. And basically, it's used for patients with loss of kidney function and inadequate waste elimination. And so we often see with these patients that they have uremia, they may have pericarditis, they may have neuropathy, and a very strong decline in cognition. And they usually have very rapidly rising potassium levels greater than 6.5 milliequivalents per liter. They can have severe metabolic acidosis with a pH less than 7.1. And they can also have fluid overload that is so severe that it inhibits tissue perfusion. The kidney replacement therapy can remove toxins like drugs and alcohol intoxication. And so what they do is they put a vascular access for them, and it's a placement of catheter that's specific for dialysis. And that's what you're seeing in these pictures above. And if you look at them, they are double lumened. And so you have one outlet that is for fluid going in, and you have one for fluid going out. And it's usually put in a central vein, usually an internal jugular vein. And it's done in a sterile environment. The placement of the catheter requires informed consent, and you get a timeout for it in the same way that you would for a surgical procedure. This catheter is not used to get blood samples, to give drugs or fluids, or to monitor central venous pressures. And usually the people that are involved with dialysis through these catheters are specially trained and hold certifications to be able to do that. Intermittent kidney replacement therapy is sometimes called hemodialysis. It's delivered over 3 to 6 hours. Generally, there's a technician or dialysis nurse that brings the dialysis machine to the bedside, and they usually do not need intensive care, but they may go to an inpatient dialysis unit for their treatment, and they use a dialysis machine to mix and monitor the dialysate. Continuous kidney replacement occurs only in the ICU because of the need for frequent monitoring and a specialized skill set for the nurse to maintain safety, and also the need for ongoing monitoring and replacement of fluid and electrolytes. And the American Nephrology Nurses Association provides policies and procedures that are related to doing bedside continuous kidney replacement therapy or hemodialysis. Patients with AKI can have a lot of different outcomes. Some will recover and return to their baseline kidney function and general health, and others may have just a partial recovery or moderate chronic kidney disease, and others may require permanent kidney replacement therapy, and some die from the acute illness. The care for these patients after discharge from the hospital varies. It depends on the amount of kidney function when the patient is discharged, and it can resolve over several months, and so they definitely need to be followed up by a nephrologist and by their primary healthcare provider so that their best outcomes can be achieved. Often these patients require frequent medical visits. They have to have frequent lab work done to monitor their kidney function. Usually they have a dietitian involved in their planning for their diet. Hopefully they're following it, although I've seen quite a few that don't. And they may be having fluid restrictions, daily weights to avoid fluid overload while their kidneys are recovering. About 10% of patients who receive kidney replacement therapy in the hospital develop end-stage kidney disease and require intermittent dialysis or kidney transplantation. And the patients who require dialysis at discharge, their follow-up care is similar to those with end-stage kidney disease. And we're going to talk about that in just a minute. So we call that chronic renal failure. So I actually combined two slides, and so don't get too confused because this is looking different. But basically, I just took two of the slides and combined them into one. Chronic kidney disease is progressive. It's irreversible. So acute kidney disease, it may reverse to normal, not too much problems. But with chronic kidney disease, it will not reverse. And the kidney function never does recover. It begins when the diseased kidneys cannot maintain the normal chemical structure of the body fluids, and ultimately ends with end-stage kidney disease. The terms used with chronic kidney disease include azotemia, which we talked about how that's the buildup of nitrogenous-based wastes in the blood, and uremic syndrome. And uremic syndrome is when you have chemicals within the blood that are similar to what you would find in the urine, which is why they call it uremic syndrome. Remember again that the table at the beginning of the chapter compares and contrasts chronic renal failure with acute renal failure or acute kidney injury. There's different stages of chronic kidney disease. There's 5 stages based on the GFR category. This is table 68.6. And I did edit this slide a little bit too compared to what you have in your PowerPoint. I would not advise you to memorize the stages of chronic kidney disease. That would be a waste of your time, but you should understand that in stage 1, your kidney function is pretty normal, but the urine functions, there may be abnormalities or genetic traits involved with it, but in stage 5, we're in end-stage kidney disease. So it's a progressive in the stages. As far as the incidence and prevalence, about 25% of patients receiving treatment for end-stage kidney disease die in the first year of dialysis. So it's not something that you're looking at being on hemodialysis for a long period of time. As far as system changes associated with chronic kidney disease, we see changes in the kidneys like abnormal urine production, severe disruption in the fluid and electrolyte balances, and metabolic abnormalities. And the healthy nephrons become larger and they work harder. Urine production and water elimination are sufficient to maintain essential homeostasis until about 3/4 of the kidney function is lost. As the disease progresses, the ability to produce diluted urine is reduced, and it results in urine with a fixed osmolarity. And as it continues to decline, the BUN increases and the urine output decreases. And so the lack of function also affects the hormone production, specifically the erythropoietin, and so we see these patients with anemia. When we look at metabolic changes, we're starting to see electrolyte changes. We start seeing urea and creatinine excretion increased. Creatinine comes from proteins in the skeletal muscles, and the rate of creatinine excretion depends on the muscle mass, also the physical activity in their diet. And so we start seeing these changes. We also see changes in sodium excretion. So we may have hyponatremia early on in chronic kidney disease, and polyuria in the mild to moderate disease. That also causes sodium losses, but in the later stages, the kidney excretion of sodium is reduced because as the urine production decreases, the sodium excretion decreases. And so then we start having hypernatremia, and that's without your patient really eating all that much sodium. Potassium excretion occurs mainly through the kidney, and so any increase in potassium load during the later stages of chronic kidney disease results in hyperkalemia. So these patients are going to be on low potassium diets. We also worry about acid-base balances because the kidneys also are what helps us keep our acid-base balance. And as you know, the easiest way to change the pH is through respiration. But if our respiratory function is not able to do it, the kidney kicks in and starts sending out bicarbonate to balance the acidemia that may be in the blood. So if the kidneys aren't working, then we're not going to get that change of blood pH, especially if there is respiratory dysfunction present. One of the things that we see is something known as Kussmaul respirations, and it increases with worsening kidney disease. And what we see is acid retention and increased respiratory action to keep the blood pH normal. And usually these patients need an alkali, so they need sodium bicarbonate to counteract the acidosis. We also see changes in the calcium and phosphorus balance because it's influenced by vitamin D, and the kidney promotes a hormone needed to activate vitamin D, which then enhances the intestinal absorption of calcium. So normally excess dietary phosphorus is excreted by the kidneys in the urine, but with kidney disease, you get phosphorus overloads. So remember that whole dynamic of if the calcium levels are low, the phosphorus levels in the blood tend to be high, where if the phosphorus levels are low, the calcium levels are high. And so we have problems with balancing calcium and phosphorus. There's problems in bone metabolism and structure because of the low calcium levels and the high phosphorus levels, and something called renal osteodystrophy develops because of that. And that causes bone pain, spinal sclerosis, fractures, bone density loss, osteomalacia, and also they lose teeth because the calcium from their teeth becomes lost. We can also get crystals forming from excessive calcium or phosphorus, and they are known as metastatic calcifications. and they can precipitate in many of the body areas. So what you would actually see on an x-ray is these little calcified areas out in the muscle or in the organs. They can lodge in the kidney, the heart, the lungs, the blood vessels, the joints, the eyes, and the brain. And often, if there's a calcium and phosphorus imbalance, the patients become very itchy. Calcium is also deposited in atherosclerotic plaques and the lining of the blood vessels. So that increases the risk of cardiovascular diseases. When we look at cardiac changes, we've already talked about how the kidney affects hypertension with the renal renin angiotensin system, the RAS system. And also it can cause hyperlipidemia from changes in fat metabolism, and that increases the triglyceride levels, the total cholesterol, and the low density lipoprotein. So again, affecting cardiovascular or increasing cardiovascular risk. They can have heart failure and pericarditis. The pericarditis occurs because the pericardial sac becomes inflamed by the uremic toxins or infection. And if it's not treated, this problem leads to a pericardial effusion or fluid in the pericardium, and this results in a cardiac tamponade. So in other words, the heart is trying really hard to do its normal movements, but because of this fluid in the pericardial sac, there's not enough room for the heart to expand. And ultimately, if that's not treated, it can result in death. The symptoms include shortness of breath from the low cardiac output, severe chest pain, tachycardia, narrow pulse pressures, which means that your systolic and your diastolic numbers are very close together, low-grade fever, and a pericardial friction rub that you can actually hear when you put your stethoscope over the left sternal border. Sometimes dysrhythmias occur because of the uremia and the uremic pericarditis. Usually, when there's a cardiac tamponade, it's a medical emergency and it requires an immediate removal of the pericardial fluid by actually taking a needle and a catheter and a drainage tube and putting that needle down into the pericardium and pulling off of that fluid. Hematologically, we talked about how it can cause anemia. It can also reduce immunity, which increases the risk of infection. The uremia also disrupts the white blood cell production and decreases the host defenses. Some of the GI changes that we can see include the flora of the mouth can change with uremia, and so the mouth contains the enzyme urease, which breaks down urea into ammonia, and so we start having a strong ammonia smell to the breath, and stomatitis, which is an inflammation of the mouth. This can cause the person to become anorexic. They may have nausea, vomiting, and hiccups are really common with people that have uremia. They're not sure why, but it may be related to the high BUN and creatinine levels. They have a tendency to develop peptic ulcer disease, and usually in the early stages of chronic kidney disease, there's not much cognitive changes, but as it progresses, You get both cognitive and physical impairment, and there's an increased risk for systemic drug toxicity, and we have to intervene when those things happen. So as far as health promotion and maintenance, we want to prevent it in the first place if we can, but we want to control diseases that can lead to chronic kidney disease. We want to make dietary adjustments to decrease the speed in which chronic kidney disease is ending up into end-stage kidney disease. That's going to include weight maintenance as well, smoking cessation, exercise, and limitations of alcohols. So some of the things that we're going to do when we do assessment is to look at weight and height. Weight gain can indicate fluid retention, and weight loss may be the result of anorexia from the uremia. So we want to know what their regular weight is and compare it to the weight that we're finding. The other thing is with osteopenia, we may see height changes as well, which is why we want to document both. We want to document the use of current and past prescribed medications and over-the-counter drugs, especially any that may be nephrotoxic and or the drug's interactions can cause kidney damage. We want to know whether the patient has had any x-rays or a CT scan with contrast medium, since we know that that can affect kidney function as well. We want to know whether there's a medical history in the family or in this person of kidney or urologic problems. We want to know if they've noticed a change in the taste of foods, because that often comes with chronic kidney disease. They may say that sweet foods just aren't appealing and that meat has a metallic taste for them. We want to look at GI and GU problems, the presence of nausea, vomiting, anorexia, hiccups, diarrhea, or constipation. These symptoms may be the result of excess wastes that the body can't eliminate. So we want to also talk about the frequency of urination, what does the urine look like, and any difficulty starting or controlling urination, because these may identify problems that influence kidney function. We also want to look at energy levels and have they gotten worse over time? Is the person having more fatigue? Because this is a common problem with patients with chronic kidney disease, and especially with patients that are getting dialysis. When I was a young nurse, and while I was in nursing school for my associate degree, my neighbor across the street had chronic kidney disease and had dialysis. And I would often go over and visit with her, but especially after she had dialysis, it really takes a lot out of them, makes them really, really tired. And she would sometimes say to me, "Oh, Faye, come back tomorrow because I had to go to dialysis today and I'm so tired." And you could just see how exhausted she was. So the physical assessments and signs, neurologic and sensory changes, fluid overload, tachypnea, hyperapnea, anemia, abnormal bleeding, foul breath, mouth inflammation or ulcerations, that's the stomatitis, osteodystrophy, protein, sediment, or blood in the urine, and skin discolorations. We want to make sure that we do a psychosocial assessment. A mental health professional is an important member of the team for somebody who has chronic kidney disease. We want to ask the patient's understanding of their diagnosis and what the treatment regimen means to him or her. We have this whole idea of Ask Me 3 for uh, health uh, care for people so that they know what their diagnosis is, uh, what the treatment is for it, why they take these drugs, and what they need to do if they, are sick, all of those kinds of things when they're on these medications. So this is part of really understanding the literacy that these patients have about their disease. We want to assess for anxiety or fear and for coping styles that are used by the patient and the family. Chronic kidney disease affects family relationships. It affects their social activity. It affects whether or not they can work. It affects their body image and their sexual activity. And we'll, kind of think about some of those things as we go further into this, and I'll show you some of the things that are needed to do the dialysis. And it's a chronic disease, and um, there's many treatment options, and there's uncertainties about the disease. Like I just said, 10% of people are dead at the end of the first year of being on dialysis. And this is not something that's hidden from these patients. And so knowing that really they could die of this disease is very scary. You want to get support and support the recommendations of the mental health professional. So if the mental health professional says that this is something that this patient needs, it doesn't matter what your opinion is. You need to support what that mental health professional has advised for this patient. It can affect sexual activities. They're just too tired and sick to want to have sex. So it affects all parts of their life. When we look at the diagnostic assessments, we're going to look at various blood and urine tests. We're going to look at the GFR estimates from the serum creatinine, their age, their gender, their race, and their body size. It can be estimated using all of these data, but it's generally used for screening rather than for the staging of chronic kidney disease. Estimation of GFR is based on a formula that includes serum creatinine. It's also useful to calculate drug dose or drug frequency when there's reduced kidney function in a patient. But as far as determining the stage of chronic kidney disease, they do a urine collection of 3 hours to 24 hours to assess the creatinine clearance. They may do a spot urine albumin to creatinine ratio as they're doing this as well. They'll also do imaging assessments, the X-ray findings, the kidney or the CT scans. So when we look at it, fluid overload due to the inability of the diseased kidneys to maintain the body fluid balance happens. There's potential for pulmonary edema due to fluid overload. There's decreased cardiac function due to reduced stroke volume, dysrhythmias, fluid overload, and increased peripheral and vascular resistance. Remember that the heart needs calcium. If the calcium levels are low, then it's not going to function as well. Also, there may be weight loss due to the inability to ingest or digest and absorb foods and nutrients as a result of the physiologic factors. These patients tend to just not be very hungry. There's also a potential for infection due to skin breakdown, immunity-related kidney dysfunction, and malnutrition. Also potential for injury due to the effects of the kidney disease on bone density, blood clotting, and drug elimination. Fatigue due to the kidney disease, anemia, and reduced energy production. Anxiety due to the change in health status, economic status, relationships, role functions, threat of death, lack of knowledge about the diagnostic tests, the disease process, the treatments. There's a feeling of loss of control or disruption in their family life. There's also a potential for depression due to the chronic debilitating illness. So when we look at planning and implementing, we're going to manage the fluid volume. And so we expect them, so our goal is that we expect them to achieve and maintain an accepted fluid and electrolyte balance. And indicators will include that the blood pressure, the central venous pressures, and the electrolytes are normal or nearly normal. The body weight is stable with plus or minus 2-pound changes overnight and no more than a 5-pound change weekly. And it does not increase more than 3 pounds between dialysis sessions. The management includes drug therapy, nutritional therapy, fluid restriction and dialysis when the patient reaches stage 5. Hemodialysis is performed intermittently for 3 to 4 hours, typically 3 days per week. And alternatively, some patients will receive peritoneal dialysis. And peritoneal dialysis uses the peritoneum as the dialyzing membrane. And we'll talk a little bit about that, and I'll show you that in just a little bit. And the purpose of fluid management is to attain a fluid balance and prevent complications from fluid overload, which we've talked about some of those. And we're going to monitor their I&O and their hydration status and assess for indications of fluid overload like lung crackles. We want to prevent pulmonary edema, and so we want to make sure we have optimal fluid balance. We want to increase cardiac function, so we expect that the patient's going to attain and maintain adequate cardiac functions, including systolic and diastolic blood pressures, ejection fractions, peripheral pulses, and cognitive status at normal or nearly normal. We want to enhance nutrition, so we want them to maintain adequate nutrition, and they should have a protein caloric intake appropriate for their height and weight ratio, their muscle tone, and lab values. We want to prevent infection. We want to prevent injury, which includes things like pathologic fractures and toxic effects from drug therapy and bleeding. We want to minimize fatigue. So we're going to want them to conserve their energy by balancing their activity and their rest periods, like my neighbor was doing. I'm going to reduce their anxiety by giving them information and giving them effective coping strategies. And we're going to hope that they're going to report a decrease or reduction in their anxiety or an absence of their anxiety. If they begin to have depression, we want them to be able to recognize what depression is and to be able to manage their depression, which includes things like expressing their feelings and assisting with their ADLs, sleeping well and reporting feeling refreshed from their sleeping, and discussing any concerns about work or leisure involvement, maintaining contact with their family and their friends, and resources like self-help groups or religious communities to give them support. And finally, we're going to talk about dialysis. So on page 1411, there's a table that compares hemodialysis to peritoneal dialysis. And so that would probably be a good thing for you to look over. When we look at kidney replacement therapies, we look at hemodialysis. And I'm not going to go into a lot of all of the settings and the procedure, but basically the patient needs to be anticoagulated so that they don't get clotting during the procedure. Although some patients are able to get by without any anticoagulation, they need good vascular access. And this particular picture is of a AV fistula, and basically what they do is this has to be able to have high blood flow. So we're looking at rates of 250 to 300 milliliters per minute, not per hour, per minute. So your average size vein really would not be able to put up with that. And so that's why they put in these fistulas. They cannulate it by inserting 2 needles, one at towards the venous blood flow and one towards the arterial blood flow. And that allows the hemodialysis machine to draw the blood out through the arterial needle and return it through the venous needle. They call it an arteriovenous graft. When the fistula doesn't develop or when complications limit its use. They also use a Gore-Tex type material in some cases, and it's used for older patients that require hemodialysis. A lot of times they can actually give the patient their medications through the hemodialysis or while they're being dialyzed. Usually it's given at the end so that the medications are in their system and not being dialyzed out. So it's important that we know when the patient's going to have their dialysis so that we don't give their medications before they go for dialysis and have it taken out of their bodies as soon as they take it and it gets put in. As far as the post-dialysis care, we're going to closely monitor them immediately and for several hours for any side effects. Common problems include hypotension, headache, nausea, vomiting, dizziness, and muscle cramps. Remember, we've changed their electrolytes very quickly. We're going to monitor vital signs and weight, and we're going to weigh them before and after to see what the difference is, and monitor their blood pressures. We expect that the blood pressure and the weight would be reduced because we've removed so much fluid as part of it. And we may need to give them some IV fluids if they're very hypotensive. Their temperature may be slightly elevated because the dialysis machine warms the blood a little bit. And but if they do have a fever, we always have to worry about sepsis because this is an invasive procedure. And so we may need to do cultures and sensitivities of the blood. And we need to watch for excessive bleeding. You can kind of see on this patient the bruising on their arm, and that's usually a result of the heparin that's been added to the dialysate. Peritoneal dialysis is really kind of interesting, and with it, what happens is they take a silicone, they say a siliconized rubber catheter, but really it's getting to the point where it's just silicone, is placed into the abdominal cavity for infusion of the dialysate. So basically, they infuse the dialysate into the abdominal cavity. It dwells. Usually, most dialysis is an exchange type thing where you put it in, it sits in there for a while so that the changes, it will draw out fluid. It will also draw out the high levels of electrolytes and the other exogenous wastes that are there. and then it's emptied. And so we have different types of peritoneal dialysis, continuous ambulatory, multiple bag, continuous ambulatory, automated, intermittent, and continuous cycle. What I'm talking to you about more is the intermittent variety. So basically, they put about 1 to 2 liters of fluid into the abdomen, and it's infused by gravity over a 10 to 20 minute period of time. Some patients tolerate it faster, some you have to slow it down. And then it stays for a specified period of time. And then it is allowed to drain back out. And diffusion and osmosis across a semi-permeable peritoneal membrane and capillaries is how it works. And so we see this especially with children. We also see it with the elderly or people who don't tolerate hemodialysis. Continuous ambulatory peritoneal dialysis is known as CAP, and basically it's going constantly in and out and in and out and in and out. It's performed by the patient with the infusion of 4 2-liter exchanges of dialysate into the peritoneal cavity, and each time it stays in there for 48 hours, 4 to 8 hours, and then the exchanges occur 7 days a week. And during the dwell period, they can use a continuous connect system or disconnect and reconnect at a later time. Most patients using long-term prefer to complete exchanges overnight with an automated cycler because then they're a little more free during the daytime and they can disconnect and not have a bag attached to them. The automated peritoneal dialysis can be used in acute care settings or ambulatory care dialysis or even in the patient's home. And it uses a cycling machine for the dialysis inflow, the dwell, and the outflow at preset times and volumes. It also has a warming chamber as part of the machine, and the functions are programmed for the patient's specific needs. They don't have to change anything. It's just done for them. Some of the complications that are associated with peritoneal dialysis is peritonitis, obviously, and they may have pain. They can get tunnel infections that can cause poor dialysis flow. They can get fibrin clot formations at the end of the catheter, which would make the catheter not work. And they may get dialysate leakage, and there's other complications as well. When we're caring for a patient that's on peritoneal dialysis, you mask. This is done in an extremely clean environment. You wash your hands, you put on sterile gloves, you remove the old dressing, you remove the contaminated gloves. You assess the areas for infection like swelling, redness, or discharge around the catheter, and you use aseptic technique to open the sterile field on a flat surface and place 2 4x4-inch gauze pads. You place 3 cotton swabs with some type of solution like povidone iodine or whatever the nephrology healthcare provider has ordered, and you put on sterile gloves. And you use cotton swabs to clean around the catheter sites, going around and out away from the site, and then you repeat with all 3 swabs. And as an alternative, you cleanse the area with sterile gauze pads using soap and water in a circular motion, moving out from the catheter site. And then you apply the pre-cut gauze pads over the catheter site, and you tape the edges down with the gauze pads. So you're doing a dressing change. Make sure I've got everything here, that I haven't missed something. Nope. And we also, before treatment, we evaluate baseline vital signs, weights, laboratory tests, and we continually monitor the patient for respiratory distress, pain, and discomfort. We also monitor the prescribed dwell time and initiate the outflow, and observe the outflow amount and the pattern of fluid, not to mention the color or anything that would imply that there might be an infectious process going on. Finally, we may do transplant. It can be from a living related donor, a non-heart beating donor, or NHBD, or from a cadaver donor. And the non-heart beating donors and cadaver donors, the available kidneys are matched on the basis of tissue type similarity between the donor and the recipient. The NHBDs are patients that are declared dead by cardiopulmonary criteria, and the kidneys of the NHBDs are removed or harvested immediately after death in cases in which patients have previously given consent for organ donation. If immediate removal must be delayed, the organ is preserved by infusing a cool preservation solution into the abdominal aorta after death is declared and until surgery can be performed. The cadaveric donors are usually people who suffered irreversible brain injury, and most often as the result of trauma. And these donors are maintained with mechanical ventilation and must have sufficient perfusion for the kidneys to remain viable in order for the kidneys to be used. The primary goal with transplantation is long-term survival of the grafted tissue. And as a result, we have to give these patients immunosuppressant therapy so that their body does not reject the organ that's been given to them. As far as the candidate selection criteria, they have to be free of problems that might raise a procedural risk, especially if it's a living donor, which means there has to be absence of systemic disease and infection, no current active cancer, no hypertension or kidney disease, and they have to have adequate kidney function as determined by diagnostic studies. So they are going to make sure that this person is really worked up before they use their kidney. They must also express a clear understanding of the surgery and a willingness to give up a kidney. Some transplant centers also require a psychiatric evaluation to assess the donor's motivations. The available kidneys are matched based on the tissue similarity, and organs from living relative donors have the highest rates of kidney graft survival. And like we said, the physical criteria has to be met. Preoperatively, they do immunologic studies because um, the major barrier to transplant success is the body rejecting the kidney. So they really try to get things as matched as closely as possible. And normally they'll have dialysis done 24 hours before the surgery so that the patient is in the best condition possible when they get that kidney and not too much stress is put on that new kidney. The operative procedure varies depending on the status of the donor, and your book goes into a lot of detail about how they do one procedure for one type and another for another. One of the things that we see with a transplanted kidney is that it usually is, this particular one is on the right iliac fossa. It tends not to be placed as high as your normal kidney is because they don't have the long ureters to be able to do that. It's usually placed in the right or left anterior iliac fossa, and it allows easier connection to the ureter and the renal artery and vein. It also allows for easier kidney palpation, and the recipient's own failed kidneys are often not removed unless chronic kidney infection is present or if there's a polycystic kidney disease. The non-functioning enlarged kidneys cause pain, and that's why they'll take those out. After surgery, the patient's taken to the post-anesthesia care unit and when stable to a designated unit in a transplant center or to a critical care unit. So post-operatively, we're going to do urologic management that includes physical assessment, especially evaluation of the kidney function. And the most common complications are rejection and infections. So they're going to receive drug therapy to prevent tissue rejection, and it reduces immunity. It also impairs healing, and it increases the risk for infection. We want to assess the urine output at least hourly during the first 48 hours because an abrupt decrease in the urine output can indicate complications like rejection, acute kidney injury, thrombosis, or obstruction. We're going to examine the urine color. Normally it's pink and bloody right after surgery, and it gradually returns to normal over several days to several weeks, depending on how well the kidney is functioning. We're going to obtain daily urine specimens for urinalysis, glucose measurement, and the presence of acetone, specific gravity, and culture if needed, if we suspect that there's an infection. Occasionally, they may do continuous bladder irrigations to decrease the risk of clot formation, which could increase the pressure in the bladder, and that would endanger the graft. And we're going to perform routine catheter care according to the policies related to the catheter-associated urinary tract infection prevention. The catheter is removed as soon as possible to avoid infection, usually for these patients at about day 3 to 5 after surgery. With the graft, they can either have oliguria or diuresis. Usually oliguria is a result of ischemia and acute kidney injury. It can also be a result of rejection or other complications. And so sometimes what they'll do is give some diuretics or osmotic agents to get the body to produce more urine. Some of the other things that we're going to be looking at is home management. Usually there's a care manager that helps plan and coordinate and evaluate care. As the disease progresses, the patient is seen by a nephrologist or a nephrology nurse practitioner, and they work with the dietitian and the social worker. They evaluate the home environment and determine the equipment needed before discharge. Um, Once they're discharged, the nephrology home care nurses direct care and they monitor their progress. Um, we also will follow them if they're on hemodialysis or peritoneal dialysis. And we start teaching self-management as much as possible as far as nutritional therapy, drug therapy, and other complications that are associated with their kidney disease or their dialysis. Um, Hemodialysis is pretty complex, um, and so over time it um, is something that they learn about. And then we want to make sure that they have healthcare resources and also that their psychosocial needs are being met. When we evaluate, we want to see that they are achieving and maintaining appropriate fluid and electrolyte balance. They're maintaining an adequate nutritional status. They're avoiding infection. And at the vascular access site, if they're receiving hemodialysis, they're using effective coping strategies. And they're preventing or slowing the systemic complications associated with their chronic kidney disease, including the osteodystrophy. They're also knowing what to report and that they have absence of physical signs of anxiety or depression. I'm not going to go through the case studies and the questions on this just because it's getting kind of long. And like I said, I left those in there for you so that you could review them. And if you look in my notes, it will show you the answers to these questions. And they're definitely things that you can review. I hope you have a good day or evening, depending on when you're listening to this. Hope it hasn't put you to sleep. And have a good day. Bye.